Perfect.
So, welcome to When Words Collide, Street Drugs Part 1, The Opioid Crisis, featuring Dwayne Clayden.
So welcome. We're going to talk about opioids. My background is was a police officer and paramedic for 40 years. So what I'm going to present is based on experiences during that time. And also that I'm a co-author on a textbook for paramedics, pre-hospital emergency pharmacology. And it's a textbook used all across North America and actually around the world for paramedic training. So we need to understand what opioids are. The word is tossed around a lot, but some different interpretations. So opioids are drugs that act on the nervous system to relieve pain. So if you're in pain, an opioid is a particular type of drug that could be given. Unfortunately, continued use and abuse can lead to physical dependence and then withdrawal symptoms. And they come in all forms, come in tablets, capsules, powder, or liquid. So why would somebody take these pills? So the heaven to it, the euphoria to it, is the brain associates the action of taking the opioid with a pleasurable reward event. So that's the way we're set up. It's the reward punishment system, and we really don't want the punishment. So we look for the rewards. And so that's just the way the brain is wired. We crave for the positive. And the brain learns quickly what are positive and what are negative experiences. So for example, if you touch the hot stove, the brain learns that that's not a good thing to do. But the brain also learns that all sorts of substances, opioids included, but also alcohol can be a positive experience. And so it seeks that. The other part to the hell to it is that because of the intense high that's produced by the opiates, it becomes extremely addictive. And sometimes that addiction can occur in as low as 3 days. For others, that may occur over a period of weeks or months. The biggest challenge, though, is that this dependence can lead to more and more of the drugs being required and lead to respiratory depression, which is the slowing of your respirations and then death. There are 3 different forms of opioids, and the one is natural opioids. So that goes back to the 3400 BC, where opium was derived from the poppy seed. And so that's natural because it occurs in nature. Morphine is derived from the opium plant, and so it's also natural. And as is codeine, while it is synthesized, meaning it's man-made, it was isolated out of the opium plant. And then there's semi-synthetic opioids, which means that they were created in the labs, but created from the natural substances. So that means that heroin, Vicodin, and oxycodone, or OxyContin, as it's also known, comes from the opium plant, but was specifically made and created in a lab, which means they took out some substances that didn't need to be there to try and get a pure substance. And then the last one is fully synthetic opiates. So these are drugs that are completely made in the lab. They're not based on the plant in any way other than the chemical formula would be the same, but they're completely created in the lab. The idea is that in each of those processes, when you go from the natural opiate to the semi-synthetic opiates, you've taken out some of the side effects that might be bad side effects. And when you get to fentanyl, you've taken out a lot of the side effects because it's created. So one of the side effects of both the natural and synthetic opiates is that it decreases your blood pressure. So over time, that is taken out. And so when they created the drug fentanyl, it's a good drug to be used by paramedics or the hospitals for people who have severe trauma, because it can be given to somebody whose blood pressure is low, but still treat the pain without worrying about the blood pressure going even lower. So there's a number of opioids, and these are the main ones that you may have heard of or be familiar with: codeine, Demerol, morphine, oxycodone, methadone, heroin, hydromorphone, fentanyl, sufentanil, and carfentanil. And the ones we're really going to be most worried about is the fentanyl, sufentanil, and carfentanil. So if you're wondering, how did we get into this crisis? Where did it start? Here's some big staggering numbers. These are US numbers, because in Canada, we really don't keep great numbers like this. So the US spends $457 billion on prescriptions every year. The cost of prescriptions has gone up 208%. and these stats go up to 2015, 2016. So in 8 years, it went up by 208%. The median salary of a CEO of a pharmaceutical company is 14.5 million a year. Drug companies spend 6.4 billion on advertising. This is just in the US alone. And they also spend 24 billion advertising and marketing to doctors alone. So that's where some of the problem came, is that the doctors were told that OxyContin had few side effects and wasn't addictive, and yet we found out otherwise. So when we look at the deaths between 1999 and 2017, again in the US, you can see that there was a steady increase in overdose deaths from any opioid, but certainly really started to increase in 2014, 2015. These are the number of deaths in the US from synthetic opioids, which would primarily be fentanyl. And so you can see that it was really mostly a straight line for many years. 2013, a little bit of an increase, 2014, 2015, and then it really took off in 2016 and 2017. And those trends have continued through 2018, 19, and looks to be into 20 as well. And these are the deaths in the US from heroin. So some thought that heroin was a drug that was going to go away, that the opioid overdoses would become more prevalent with OxyContin. But while that did happen, there's still a significant number of heroin overdose deaths each year. So what we're talking about is the potency of the drugs, and that's what we're concerned with. Each drug is a little bit different. So just give me a second. So if we look at all those drugs again, and we say that morphine is a relative potency of 1, so that's just a baseline for us to work with. You can see that codeine and Demerol are 10% of what a dose of morphine would be. It's not as potent. And then it works its way up. Oxycodone is 1.5 times, heroin 5 times, fentanyl 100 times more potent, sufentanil 1,000 times, and carfentanil 10,000. So I know that right now these are just numbers, but if you keep them in your minds for a moment or two, we're going to show what significance that means. And here you go. So if you look at heroin, 10 to 12 milligrams is what it would take to have a lethal dose. And that's what it looks like compared to an American dime, which would be the same as the Canadian dime. Fentanyl, significant less. And then carfentanil, 0.2 milligrams, which is really just a mere speck. So fentanyl and sufentanil really bring dangers to first responders, whether it's paramedics, police officers, firefighters arriving first on the scene, or those arriving to give care. So you can see the penny in this first responder's hand, and you can see the white dots on there. That is how much sufentanil it would take to overdose that person. So if a first responder was not wearing gloves, or a good Samaritan arrives on scene and is trying to help out, and that much of the drug touches them, that could cause an overdose for them. The other challenge is that those drugs, fentanyl and sufentanil, are put into pills that look like oxycodone or oxycodone. Different manufacturer's name. So you can see that the difference in pills. Now, if you'd had the real oxycodone and then got the counterfeit one, you might say, oh, well, the color is a little bit different. But I'm sure all of us, not all of us, some of us would have been to the pharmacy where one time your prescription is filled, they give you one brand of the medication. Next time you go, they give you a different brand or a generic of the medication, and they look different. Some are circles, some are tablets. So really, unless you were really paying attention to things, you really wouldn't know whether you were getting the real ones or not. They look so much alike. These are fake Percocet pills, very professionally done, and you wouldn't notice the difference. So here again, here's 2 pills, and one contains fentanyl, and the other is a legitimate pill. And looking at these ones even side by side, it's hard to tell the difference. If you looked really closely, now keep in mind these are blowing up with these pills as well. So if you're looking at these pills in your hand, you wouldn't notice anything different. With the top one blowing up, you can see that the stamp on the M367 isn't as clear as the bottom one. But again, not many people are checking their pills that closely. And if you're an addict and somebody sells you the pill, you're really just taking what they're giving you. It's a huge problem because the RCMP, the DEA, city police forces are all finding packages of these synthetic pills. And the scary thing is how professional the systems are and how easily they're made. So the other thing that comes up is, when we hit this opioid crisis, why would people keep taking pills that contain opioids even though there were overdose deaths? And so that goes back to the brain wanting what the brain wants, that pleasure. And the weird thing in this is that in the addict's mind, pills that cause the death in someone else, one, it's not going to happen to them. And two, that must mean it's really good stuff. And so to us, that may be warped thinking, and yet that's the process that they're going through, that this must be really good, and it's not going to happen to me. So as mentioned, the fentanyl is chemically related to meperidine, which is Demerol. It's 100 times more potent than morphine. It is used in anesthesia, and actually when you saw some of the early straight lines, fentanyl is not a new drug. As a paramedic, I've been using it for more than 25 years. So it's not something brand new. It was something that was used in the emergency departments. It was used in surgery. Paramedics used it. But it really wasn't a drug that was prescribed to the general population until the last probably 8 years. It has a very, very rapid onset of action. So what that means, when you take it, it's going to have its effect almost right away. The duration is short. And it's available in a number of forms, and I'll show some pictures of those in a minute. So it's available in lozenges. Ironically, fentanyl lollipops, which was actually featured through one season of The Good Fight, where one of the lawyers, well, actually two of the lawyers went to court with these lollipops, and they were actually fentanyl lollipops. Buccal tablets means that you can put them in your cheek and they'll be absorbed that way. Transdermal patches, like nicotine patches, can be just placed on the skin, and then in injectable formats. Fentanyl, even though it's a synthetic drug and they've tried to take out all the impurities they can, it still has the effect of an opioid. And so depression, crying, suicidal thoughts, behavioral changes, anxiety and irritability, and hallucinations are all common side effects. So sometimes a drug will have a side effect that is desirable. Unfortunately, in this case, there aren't any of those that are desirable side effects. So this is the downside of taking the drug. And here's why it's become so prevalent. Aside from the pharmaceutical companies who initially made billions of dollars off of the opioids, here's how it works now. So a kilo of pure Chinese fentanyl, and most of the fentanyl comes from China, can be purchased for less than $5,000. So that would be a gallon ice cream bucket size, can be purchased for $5,000. They would then take that agent and they would cut it with talcum powder, baking soda, whatever they can find, and they would stretch that 1 kilo into as much as 24 kilograms. Then each of those kilos can be sold individually for $80,000. And then if the organization has a pill press, which we'll get to in a second, each kilo can then potentially generate $1.6 million worth of the pills, the fake OxyContin pills based on the deadly drug fentanyl. So for $5,000 for the fentanyl, for another $4,000 to $5,000 for the drug press, and another $1,000 for coloring and the cutting agents, for $10,000 to $12,000, you can swing that around into about $1.6 million. And so this is what one of the pill presses look like. So this one's a small motorized pill press. On the top right, you can see the funnel. So that is where the mixture is poured in. And then there's, I forgot one of the things they would have to buy too, which you can apparently get from China, is the stamps you would need to say that it's oxycodone, OxyContin, 80 milligrams or 325 as we saw for the Percocet. So those would cost $500 to $1,000 as well. So now we're up to $13,000 to make your 1.6 million. You can see the different colored pills in this picture, so that's just a different coloring agent. And the reason you saw on some of the earlier pills where the color was off a bit is because the people who are creating this are following an exact formula. So they're getting as close as they can. And with fentanyl, you don't have that room for error. Here's another picture of the mixer on the right, and then the pill press in the middle. And then just another view of the press that will punch out these pills. Motorized ones are obviously faster than some that are hand cranked. So as fast as you can hand crank, you can also put them out as well. This is one of the lollipops that for fentanyl. So, and the reason fentanyl would be in this format is really for cancer patients in the hospital. So rather than having the injections, which have a very rapid onset, you want to delay, then by using something that's more delayed, like a lollipop, will work. Or in this picture now is the transdermal patches. Again, generally used for cancer patients or somebody with very, very severe chronic pain. Just handling these patches can also transfer the fentanyl to you. And some people have shown mild overdose reactions just by handling them. And I've never, I just shake my head, I guess, at the creativity of the criminal element. So what they started doing was collecting the patches that were discarded in the hospitals, cutting them into very thin strips and putting them into cigarettes, and thus the fentanyl could be smoked, not having the full potency as it shows here on these patches, but still with enough potency that there was an effect to it and that people would buy them. Now we're going to talk about carfentanil, which came into, I guess, our vocabulary a couple of years ago, and it's become present in the U.S. markets and in the Canadian market as well. So as bad as fentanyl was, this is 10 times or 10,000 times more potent than morphine and 100 times more potent than fentanyl. So this is where that little speck can create an overdose. And the depression to the central nervous system is almost immediate, and the ability to breathe is greatly curtailed. So it really knocks out the impetus to breathe. And so tiny particles through the nose-mouth injection can create a life-threatening emergency. Skin contact of any of the drugs is dependent on a whole bunch of things. So if your palms are sweaty, your hands are sweaty, then it's going to be absorbed more than if your hands are dry, but still can be absorbed. And carfentanil is used as a tranquilizer for extremely large mammals. So elephants, hippopotamus, rhinoceroses, those are where this drug is used because it requires that level of analgesia, that level of effect to knock them down. And if you've seen the tranquilizer darts, you know they're not that big. So taking down a big animal is a big deal. And so this is just another comparison of how much of a drug it would take to kill you. And so again, a concern for pre-hospital care providers, first responders, the danger in that. So that's covered kind of part of the opioid crisis, I guess the more prominent part of the opioid crisis. Now we're going to talk about kind of the old part of the opioid crisis, which has been around probably since the mid-50s, really, and that was heroin and the different forms of heroin that were around, again, falling into the same category of an opioid. So heroin gives the experience of a warm feeling of well-being, and just envelops the user with a euphoric event. And so that's what the brain craves. The challenge is that within 6 to 8 hours, symptoms such as nausea, vomiting, chills, excessive sweating, muscle and bone pain start to follow, and that's the hell that really starts. And so that's the start of the withdrawal symptoms. And so with any addict, whether it's drugs or alcohol, they will develop a tolerance. And that means that if today you took a milligram of heroin and that gave you the euphoric events, over time, and this is definitely person dependent, your metabolism dependent, that milligram won't have its effect anymore. So, first time I had a beer, I thought I was absolutely drunker than I would ever be. And then, within a few months, it was a couple of beers and then 3 beers. So same sort of thing with these drugs is that over time you need more of the drug. So the problem with heroin and the opioids when you're in the full addiction is that, maybe it's 6 to 8 hours till you have your withdrawal effects, but that time will start to lessen. And instead of 8 hours, it'll be 7 hours. 7 hours, it'll be 6, and then it'll be 5. So you have to be constantly getting a new fix. And that doesn't end, when the day ends. It doesn't end at 10 o'clock at night because now you're going to sleep. This is a 24/7 problem that the drug has to be replaced. And unfortunately, faster than before. As bad as heroin was in the 60s, 70s, into the 80s, it was rather predictable. And the addicts knew that if they took a certain amount of heroin, if they were buying from the same dealers, the effects would be the same. It all changed when fentanyl started to be imported, because no dose was equivalent to the one you had before. Dealers were buying from multiple producers of the product, and so that changed. So, you may have seen the TV clips of Hastings Street in Vancouver. Maybe you're familiar with it, you've driven past. And when I initially saw that, I thought, oh, wow, there's a block of people who are all addicted to the opioids or heroin. This is terrible. And I based that on what I had seen on the streets in Calgary. In Vancouver, Hastings, it's not that. Hastings, I don't even know how long it is, 10, 15, 20 blocks long of addicts that are just looking for their next fix. And even though it's not in the news as much anymore, the overdoses in Vancouver have not slowed down a lot. The overdeaths have not slowed down a lot. And some paramedics that I've talked to in the last few years talk about essentially walking down Hastings Street. They don't even take their ambulance with them because they literally go from one overdose to the next overdose to the next overdose. And some of those overdoses are lying next to each other, 3, 4, 5, 6 people who have overdosed. The reason they overdosed is the same dealer who bought from the same supplier who is selling tainted heroin, or they've been taking the tainted pills, what they think is OxyContin, which is really just talc powder and fentanyl introduced in it. What's on the screen now is what's called black tar heroin. So this has to be heated and essentially melted down, put in a solvent so it can be injected. Some heroin, you could break off pieces of that and you can smoke it as well. And different ways of doing it. So in this case, it's tinfoil being heated by a big lighter, and then the vapors are inhaled. And in other cases, it's heated on the spoon, and a needle will be used to withdraw the heroin, and then it will be injected. Over time, with the addicts who inject the heroin, they're at big risk for infections, all sorts of other diseases. The veins will collapse. They will have to seek farther and farther to find veins. So generally that works up their arms or works up their legs into their groin, and groin and into the armpits as well. And in desperation, they may inject between their toes, which isn't as effective as getting into a vein, but that's where it will take them. So just showing the syringe withdrawing the heroin. And here's an example of an injection site, and also so you can see the previous injection sites that are already inflamed. Infection has already started there, and for some of these addicts, that will be all over their body, anywhere there are veins that may have been accessed. So on the good side, opioids are, I believe, pretty much the only drug that has an absolute antidote. So if you overdose from an opioid, a drug called naloxone, also called Narcan, is an antidote. And so with this antidote, what happens is the naloxone completes with the opioid for the receptor sites in the brain. And so essentially what it does is it blocks the opioid from taking up those receptor sites. So once that happens, then the effect of the opioid overdose will reverse. So if the patient respirations are very shallow or no longer breathing, it will reverse that, and the patient will start breathing again and become conscious. However, one of the challenges with Narcan is it is not as potent. It doesn't last as long as certainly fentanyl or some of the stronger opioids. So it'll reverse the opioid overdose, and it will do it very quickly. Breathing that has slowed or has stopped will come back. I guess one of the challenges is, I would hate to say that I agree on anything with Donald Trump, but fake news or unreliable news is an issue. So there are a number of challenges with Narcan. One is that it is an antidote, and it's good we have it everywhere. The challenge is that it is everywhere. So the indications for giving the Narcan are the patient is difficult to arouse, there's no response from physical stimuli, but if they awaken to voice or light shake, they are not in a deep enough overdose level where they need the Narcan. As paramedics, we don't even start really worrying about somebody's respirations in most cases until they're less than 8. So normal respiration is 8 to 12. So breathing at a rate of 8 is not uncommon. And then the other thing we look for is pinpoint pupils. So that's one of the main signs of a narcotic or opioid overdose, is the pupils are pinpoint, so they get smaller. One of the challenges, though, is that in most overdoses, they're not taking a single drug. Opioid overdoses may be different in that a little bit, but I would say maybe 2 out of 10 times, even in an opioid overdose, only 2 out of 10 times when I see the pinpoint pupils, because either they were taking another drug, which counteracted making the pupils pinpoint, or whatever was mixed with the opioid countered that. So what used to be just the best sign ever for a paramedic, if somebody had breathing difficulties or stopped breathing and had pinpoint pupils, I would know that that was an opioid overdose. That's gone because of, in some respects, because of other drugs that can be taken. So I have to go with the clinical signs that the patient is difficult to arouse, their respirations are shallow, they won't wake up when I try to rouse them, and then I would decide that, okay, yes, I do need to give the Narcan, and we'll see what happens with that. Narcan is available in a number of different methods, which is great. And the best one for the emergency situation is as a nasal spray. It can be given right away, but the caution is it doesn't replace emergency care. So if somebody has overdosed on an opioid, and you do administer the Narcan to them, and they wake up, which they should right away, you still need to call 911. If you haven't called 911, they need to seek medical care, because the chances are that Narcan is going to wear off before the opioid did. So in a lot of situations, especially with the on the street overdoses, more than one dose is required. While you can get them from the pharmacy, a lot of people have just ask the pharmacy for the one dose, and even addicts will carry it, but have one dose. We are seeing more and more now that the addicts have the antidote kits, and so are sharing those, because a lot of the overdoses require more than one dose. So when it's given, as a paramedic, if I had the choice, I would give it intravenously. I'd start an IV and give it, because it's going to work right away. When it's injected into a muscle, it doesn't work quite as quickly. When it's sprayed into the nose, it is quite effective and will have a turnaround kind of between the two, maybe not quite 2 minutes, but less than 5 minutes. And the effects of the Narcan naloxone will last about a half an hour to an hour, but that is dependent on the severity of the overdose, on what is taken. So again, if a big dose of the opioid is taken, so the fentanyl is close to a fatal dose of fentanyl, it is definitely going to take one dose of the Narcan to reverse that. So just one caution is that 100 administration doesn't mean 100%. So right now we're at the point where we are very much over-administering naloxone, which is a good thing because it's better to err on the side of that. But what sometimes is reported in the press is that police, EMS, or fire department, or any of the walk-in clinics, etc., administer 100 doses of Narcan this month and saved 100 lives. There's not that direct correlation. And that's not to lessen the problem, but it does give the impression that Narcan is a miracle drug. In some cases it is. Where the challenge comes in is that the opioid, when it knocks out the respiratory center in your brain, it's the same as any form of you not breathing, whether that's from a cardiac arrest or from a drowning or a suffocation. There is a window of 3 to 4 minutes where the brain can still be revived, when the brain can still be resuscitated. If the overdose and the patient stopped breathing outside of that 4-minute period, so if it happened 8 minutes ago, 10 minutes ago, 15 minutes ago, 20 minutes ago, then the Narcan isn't going to work. So the same system, I guess, process that the brain follows is if you drown and you're pulled out of the water and right away somebody does mouth-to-mouth and does some chest compressions, your chance of survival is good. If you have a heart attack, somebody does CPR. I'm still old school. I'll talk about giving mouth-to-mouth or ventilations, or we as paramedics will still ventilate the patient. But if you started CPR right away, you've activated the 911 system, then the chance of survival is good. Same with an overdose. The longer the time is, the less likely the Narcan is to reverse the effects. So therein is the challenge, is that unfortunately for some paramedics, you know, the toughest thing for a paramedic is that you have a patient die, and you've worked as hard as you could to help the patient, and sometimes you can't revive them, and that's difficult. When there's the expectation that has been pushed out that naloxone is a cure-all and it's going to save everybody, then that makes the challenge even worse, because that's not always possible. So I think, you know, the COVID-19 problem has overshadowed the opioid issue, but it hasn't gone away. It's still very much there. And let's give a quick story of a call we went to where husband and wife were not breathing in the house, and they had become opioid addicts for reasons treating a medical problem. Their kids were in the kitchen watching TV, and this had happened before with this couple. They had been picked up by the ambulance before, and the kids had been given directions on what to happen if mom and dad were to be unresponsive again. And so it was the kids who called 911. We weren't able to resuscitate in this case. So the idea that the opioid crisis is a problem of downtown Calgary or downtown Vancouver, Hastings, or wherever it is, it runs much, much, much deeper than that. The challenge is that there aren't enough treatment centers, if an addict right now wanted to enter a treatment center, it's unlikely they would be able to because there aren't enough of them and there are not enough beds, and that's a challenge. And so that's the crisis that has been created, and that's what we're dealing with now. So there's different varieties of the spray. So this is one form of the Narcan spray. This is another one. On the left-hand side, you can kind of see the foam piece, so that would go into the nostril. I mean, the first one is the best one for people who don't have medical experience to use, because there's nothing to put together. You just simply insert it in the nose and you squeeze and the spray goes in. This one, there's a little bit of assembly required. They often are very well identified, say naloxone kit. This is another kit that also has a shield barrier for mouth to mouth. Now we know that that's not recommended anymore. I would guess that it's a family member that you might want to give mouth to mouth, and you'd use the shield. And not to end on a horrible note, this is my dog marking my page for me for reading to lighten up the mood a little bit. I'm going to actually exit out of this, and we have a few minutes left, so I'm going to look to see if there's any questions here. Okay, so
somebody wanted to know if you would be sharing the notes, or if they could have a link to your notes.
My understanding is this is recorded, so they will be able to have access to this through the recording.
Any other questions? Randy says, any suggestions for better education of the masses?
Oh boy. I guess I have I don't know if it's personal bias in this. I mean, my frustration is I watch this being created by the drug companies, and in some respects the overprescription of the opioids. And I'm not really sure why the drug companies or the physicians would accept the fact that OxyContin was a safe drug when everything in my limited knowledge as a paramedic or having researched for the textbook and worked with a physician on this, there's nothing that has ever suggested that opioids were safe to use. There's always been the challenge of overdose. There's always been the challenge of addiction. That has always been there. So for a number of years have said, no, this drug is safe without any studies. Yeah, I guess, I'm gobsmacked would be the wrong word, but maybe the one I'll use on here. I just can't believe it happened, and the tragedy, especially in the last 4 years that I've seen as a paramedic, is horrible. It's probably the worst crisis that I've ever had to deal with, and the most heartbreaking. And it was entirely preventable. And even though there are small steps being made for addiction centers, it's a drop in the water. It's not even close to helping with the problem. That's going to be a big challenge, and it's not going to go away, and that's the scary part.
Okay, and so Nicole has a question about, not on the drugs listed, she needs to drug her character so she can be kidnapped, and then given a drug so that she's conscious but hallucinating and not aware of her surroundings. Any ideas?
Sure. The best idea is you need to come to my presentation on Sunday about drugs as a murder weapon. So in there, I will talk about that. So probably the drugs you'd want to look up is benzodiazepines. So most of them known as Valium, but there's a couple of others. Lorazepam, yeah. And anyway, if you look up benzodiazepines, it will tell you about that. So the injection. The challenge you will have, unlike TV and movies, is that few injections work immediately. So injecting somebody with the drug doesn't mean it's going to have its effect right away. The best way to get the drug into the system is through a vein. So if you're good enough that you can quickly put it in the vein, that's the fastest route because it will get to the heart right away and to the brain right away, and then have the results you have. Putting it in a muscle means that it's going to take 3 to 5 minutes to have its effect. If you put it in the thigh, maybe 2 minutes to 4 minutes sort of thing. So the other suggestion is that if you look up benzodiazepines, or send me an email afterwards and we can talk a little bit more about this, is that you create a drug that is just a stronger version of a benzodiazepine, but it's completely made up by you, and will have faster effects than what the actual drugs have. I don't know if that helped. Nicole, did that help a little bit?
Okay, and asking for both personal and fictional reasons. My family has a history of addiction, so I don't drink or smoke or do anything harder than sugar. I know that some of these drugs, when used medically, can form addictions very quickly. How quickly can this addiction happen? One doctor estimated my sister with chronic pain might be susceptible after 1 to 2 medical doses. Is that legit? How do we estimate risks? Thank you.
Yeah, that's a great question. Um, so the addiction risk is individual. So unfortunately, some people are addicted with the very first drink of alcohol, are addicted with the very first OxyContin pill, are addicted the very first time they take any addictive substance. Um, but certainly a family history of addiction would suggest to me that absolutely what you've done is err on the side of caution. That um, that would be a worry. Um, a few of the drugs, cocaine is highly addictive, and within a few uses can be addictive. Methamphetamine is something like 80 to 85% addictive on the very first dose, and so something like that. I mean, there's no margin for error for any of us really if you look at that number. More you know about methamphetamine, for the shameless plug, which I'll talk about from 5 to 6 today. Um, uh, yeah, it's a nasty. I mean, it's a nasty drug. It's just all harmful chemicals is essentially what it is. But the addiction rate is very, very high, and the recovery rate for addicts is very, very, very low. So in most programs, a good um, success rate is 9 to 12%, making it through an initial addiction program. So with methamphetamine, it's 1 to 2%. It's just incredibly low. So it's probably the hardest drug. It's one of the most addictive drugs and one of the most difficult to wean yourself off. And it it can take 8 months to a year to totally destroy your body with methamphetamine, and the addiction becomes worse. As I mentioned, instead of with the heroin, every 6 to 8 hours, with methamphetamine, they can need a hit every couple of hours, 24/7, and so that repetitive need just destroys the human body. It's not meant for that. Let's take that.
So we'll ask one more question really quick, and this will be the last one. On an episode
Yep.
of Perks and Quarks, I heard about research saying that long-term opioids are not effective in pain management. Do you know anything about this?
Yeah, so that would pretty much go with what has happened. I mean, they thought that OxyContin was going to be the miracle drug for long-term pain management, and it just becomes highly addictive, and you just need more and more and more and more of the substance um, to get the same effect. So, I mean, the medical system is backtracking now on that. Unfortunately, there hasn't been a good alternative yet. Um, but certainly, some of the things we don't want to do that our doctors tell us to do is diet and exercise. And I'm pointing to myself when I say that. From work as a paramedic, I have a chronic back problem, and certainly losing, I won't say how many pounds would be good for me, and exercising more would be good for me. Um, so I guess instead of doing that, I endure the pain, and I haven't gone to, the painkillers. But those are some of the things that are definitely the best things for the long-term care. The opioids were never meant to be long-term. They were meant to get you over the hump, that initial trauma of the broken leg, that initial trauma of the traffic accident, the initial trauma of a serious back injury, those sorts of things. They were meant to tide you over for a few days until other treatments, physiotherapy, those sorts of things, or um, casting, splinting could come into place. Somewhere along the way, we lost our way, and they just became for some reason, a forever. We'll just keep the prescriptions going. Right. Thank you, everybody, for hanging in there during that rough start there, but we made it through.